We have people joining us from all over the country. So first I should say, my name is John Soski. I am a person in long-term recovery from alcohol and drug addiction and the community engagement coordinator at RICARES. For those of you who don't know us, RICARES is a recovery advocacy and harm reduction organization based in Rhode Island. We have 4 program areas: peer recovery support, recovery housing, individual and system level advocacy, and education. We define our mission as being at the intersection of trauma, recovery, and social justice. And we take our slogan from the movement of people with AIDS: nothing about us without us. We think the voices of people in recovery and the voices of people who use drugs must be at the center of every discussion of addiction and recovery. The conversation today came out of actually a Twitter back and forth between Laura, Carly, Seth, and I immediately, shortly after the COVID lockdowns began. And there was a lot of concern over liquor stores being closed, which at least in Rhode Island, we've thankfully avoided, and how to help people we work with through precipitous, unplanned alcohol withdrawals. And in that conversation, someone observed, I forget who, that peer recovery specialists often learn harm reduction techniques for opioid use disorder, Narcan, fentanyl test strips, not using alone. But at least in Rhode Island, we don't normally get the same kind of training in harm reduction techniques for alcohol. And at the same time in the discussion, I was concerned some about making sure peer recovery specialists stay in their lane. Like, severe alcohol withdrawal can be life-threatening. It requires medical intervention. And I was a little worried about us stepping into areas that we shouldn't step into. I think Carly and Laura convinced me I was being too rigid. And then out of that discussion, we came up with the idea for this brief webinar. The idea is that we simply will introduce people to some harm reduction techniques for alcohol and resources for those techniques. Then we'll talk some about medical dangers with alcohol withdrawal, when you really need to call in a doctor. And then we'll reflect some on ethical issues that can come up when we adopt new roles, especially in contexts where we're collectively negotiating trauma. So to briefly introduce our speakers today, Carly Larson, she, her, hers, is a non-abstinent person in recovery, certified peer support specialist, and a drug decriminalization enthusiast who is currently involved in her state's initiatives to rectify the challenges brought on by the poison drug supply and overdose crisis. Seth Clark, he, him, his, is a board-certified addiction medicine specialist and harm reduction advocate who works as a physician at Rhode Island Hospital Lifespan Recovery Center and the Rhode Island ACI. Laura Hoge, she, hers, is a psychotherapist, adjunct professor of social work, and a community organizer based in New Jersey. So we're going to start with Carly. Carly, will you talk to us about what peer recovery specialists can do around alcohol management and alcohol tapering?
Absolutely. So I think what's really important to remember, and what we always keep in mind within our organization, is we don't want to send people to more harm. So there are absolutely hard lines that anytime I have supported somebody that it is, okay, it sounds like medical attention is needed. However, we are very understanding that medical attention can lead to a lot of harms depending on identity, depending on financial situations, stuff like that. So what that means is working with people who are trying to change their alcohol use, and that could be due to a cutoff of a safe supply like we thought was going to happen. That could just be changes that they want to go through. So I don't tend to give people, when I support them, like hard numbers. I don't say like, great, you are going to drink 1 drink an hour and this will fix the situation. Everybody is different. I know for me, 1 drink an hour when I was personally going through the detox was not enough to start with. I will say there are some tools out there outside of the medical field that can help people develop a taper schedule. So HAMS, Harm Reduction, Abstinent Moderation Support, which is a Facebook group, virtual group, has some pretty good guidelines. And I know that they've worked with some medical professionals to develop those. So I know when I support people with tapering and everything, it's really just managing some symptoms. Like I said, there is a certain line where absolutely medical attention would be needed. And so for that, that's to me seizures or DTs. But there's a lot of ways that we can make people more comfortable and not have to seek out medical care. So for that, to me, that's going to be like regulating body temperature, never going to an extreme though. So if they are experiencing hot flashes, how can they cool themselves off? Typically, I think about some ice wrapped in a washcloth and pressed on certain pressure points. If they are experiencing extremely cold temperatures or cold sweats, what are some ways that we can raise their body temperature, never to the extreme. So I'm not telling them if they're freezing, go take a super hot bath, because we really want to keep the body on a softer path to baseline. Some of the other things that we talk about are body aches, fevers, headaches, which can oftentimes be managed with some kind of ibuprofen, Tylenol, stuff like that. We also want to be careful that we're not taking too much ibuprofen and Tylenol, because if you have been drinking to the point where withdrawal symptoms are pretty severe, then there's probably some organ damage that's being done, and we don't want to further contribute to that. As seemingly silly as it is, Pedialyte and Gatorade go a long way when it comes to this. So really regulating some blood sugar there, helping sodium levels in the body, little kind of household items like that. We often have people who have gone to the ER multiple times for detoxing. And so they tell us like, hey, I was literally told the last time I went to the ER that I've been here too many times for this issue and I will not be seen. That leads to a whole other conversation that we don't have time for. So really, if people are not wanting to seek medical care, I think that there are steps where we can help them, knowing that we are not medical professionals, knowing that there is fatality aligned with alcohol withdrawal. Some of the other things is like that emotional support. Like at the end of the day, detoxing sucks. There is no way that it feels nice or goes by easily. And so there's kind of a lot of reality checking that we have to do, that like it is going to suck and it's going to suck for a little bit of time. Here's kind of a way to make it suck less. It's never a fun time, and especially if we see like a surprising cutoff of supply is when I think it can really cause some damage. So when we are looking at supporting with moderation management, like I said, I don't provide hard numbers. I think people aren't robots. So while we sometimes drink the same amount all the time and we get into our routine, every day can kind of be different, and our body needs something different every day. If they're needing more kind of support around that, and they feel that support groups are a good structure, some of the ones that have proven pretty efficacious are moderation management. Another organization is moderate drinking. And then we have HAMS, which I have heard some personal testimony that one felt really supportive and helpful. So I think it's really important to keep in mind that abstinence isn't always feasible for somebody, or not on the timeline that it's often promoted. A lot of the times it's like, just go abstinent. And that can be really dangerous. So we really want to make sure that we're educating the people affected and supporting them in a way to slowly decrease their use to kind of see the least negative consequences happening. I feel like there's another question I was supposed to answer. I am notorious for this.
You've covered a lot. We can always come back in. I mean, we're leaving a time for questions at the end, so we can always come back to you.
Great.
Seth, would you like to take us to the next stage?
Yes, absolutely. First, I want to start off by echoing all of Carly's points. Very, very well said. We've not done a lot to engender a lot of trust, specifically with a lot of the patients that we're discussing now in the healthcare system, for all the reasons that Carly illustrated. So I do think it is important to take a nuanced approach from the healthcare side, realizing that folks are rightfully mistrusting of a lot of our motives and the way that they'll be treated when they do present for care. So I think being realistic and acknowledging those, but also being realistic and realizing that these are potentially fatal consequences. So I think just not to reiterate what Carly said, but just to emphasize that, because my task was more to look at the medical side of when someone really should reach out for medical supervision and medication management because of the potentially fatal consequences of alcohol withdrawal. So I am going to try to share my screen now. We'll give that a try. And I don't know that this is going to work.
So Seth, it's Gail. So
Hey.
yeah, welcome everybody to Cobray Technical Issue. This is very typical of how things go for us. So Seth, you should have, are you doing a slideshow?
I am, yes ma'am.
Okay, so if you have your slideshow opened up on your, just have it opened up, then you should be able to sort of take your mouse down to the bottom of your screen, and there should be a green button that says share screen.
There is, I think it wants me to get out of Zoom and back in to allow permissions, so I might skip it.
Okay, because I'm looking, let me just double check my, yeah, I have everything set up so that you should be able to share.
Is that working?
Yeah, we see. Is it like Hawaii or something like that?
No. Oh, I don't know. It's whatever came on the Mac.
Awesome.
Do you see my PowerPoint now?
Yeah.
Okay, great. Thank you. Well, thank you guys. Yes, so I'm a addiction medicine doc, primarily at Rhode Island Hospital on the addiction medicine consult service. So addressing concerns on patients who are admitted for various reasons, not atypically alcohol withdrawal, but also work in the outpatient setting at our Lifespan Recovery Center and doing primary care at the prison system in Rhode Island. So my objectives here, help to identify folks who are at risk for alcohol withdrawal, not only for symptom management, because as Carly mentioned, it is miserable, but for the purposes of this, identifying who is really at risk for severe medical consequences and how to best address those. So understanding the basic treatment options that we do have, and then how to access those. Specifically here in Rhode Island, hopefully a lot of this will be generalizable. So just in general, alcohol withdrawal, the symptoms that occur on someone who's chemically dependent when they have to abruptly stop alcohol. So again, to Carly's point, not only is abstinence not the answer for everyone, it can actually be dangerous for some folks. So in general, alcohol is a central nervous system depressant. The body really fights to maintain homeostasis. So when you're intaking a lot of alcohol, it's telling your body basically calm down signal. So your body is ramping up its natural wake up, go, 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 fight or flight signals itself. So then we take away the depressant of alcohol, we're just left with the overexcitation system from our body. And that unopposed by alcohol causes, insomnia, restlessness, tremor, anxiety, and then ultimately on the far end of the spectrum, seizures, hallucinations that can ultimately lead to death if not addressed. So these symptoms typically begin within a day of abrupt cessation, quicker in others, longer in some people. And it's really a factor of genetics, of alcohol consumption, of other medical comorbidities. And so again, to Carly's point, it's very case dependent. You know, some folks who are at risk at lower drinking levels will have the withdrawal symptoms earlier or later. It really just depends on the individual patients. But typically after we get past, 48 hours, definitely after 72 hours, if these symptoms haven't started, then they're unlikely to present after that. That being said, if someone does start to have symptoms within this 24 hours, the symptoms can continue for, up to a week with severe symptoms, and then really protracted withdrawal, weeks to months for some of the other symptoms. And again, the symptoms and severity are based on the amount of alcohol consumed and a number of other medical factors. So it's really a case-dependent presentation. So in the medical field, we try to quantify things as much as we can. So there's a number of scales, a number of ways to assess these symptoms and the severity. So we try to break things down into mild, moderate, and severe alcohol withdrawal symptoms so that we know when to be concerned. So the moderate and severe, so 2 and 3, those are the ones where we really recommend medical management. 2 being the symptoms that can be managed in the outpatient setting. And then 3, once we get to the symptoms of disorientation, impaired attention, some hallucinations, concern for seizure, those are the folks that really need to be observed, because they need IV medications, high dose medications quickly to really prevent the fatal consequences. So that's how we try to kind of stage this. And some folks will jump straight to the severe symptoms pretty quickly after abrupt cessation. Other folks will progress through stage 1, 2, and 3. So just because someone only has anxiety and tremor and insomnia does not mean that they'll stop there and that they won't progress to the others. So that's really what we want to monitor over the first day or so. And then we have the short alcohol withdrawal scale, again, that kind of helps us triage who's at risk based on the symptoms. So looking down at the bottom, it's a 12-point scale. So if someone has less than 12 on the scale, currently they're mild, so that means they're not really at risk for the fatal consequences. But again, that depends. If you do this scale, 5-6 hours after their last drink, they might be less than 12 at that point, but then it will continue to progress. So it's really important to monitor these symptoms over time. And again, those tools really just try to give you specific numbers, because like I said, we try to deal in absolutes when we can. It's really more of a whole picture and kind of the trends of the symptoms that we're doing. Here are additional tools that we use to assess risk. So looking at who is at risk based on presuming that they're going to have to abruptly stop drinking. So if there's a shelter-in-place order, or liquor stores are closing down, trying to risk stratify who is going to be high risk for severe withdrawal when they do have to stop drinking alcohol. And so one good tool that we have is the Severity of Alcohol Dependence Questionnaire. So that's a self-administered questionnaire. It's 20 items. And then that'll give us a score that will, based on someone's drinking patterns, drinking behaviors, give us an idea of if they will be at increased risk for severe withdrawal. Then the PAWS, the Prediction of Alcohol Withdrawal Severity Scale, that's something we use as practitioners, because there are some physical exam findings that are included on that. I think I have a picture of that on the next one. That gives us an idea, again, of that mild versus moderate to severe risk. And again, it correlates heavily with the amount of drinking, but to Carly's point, it's case by case, right? And so we don't deal in hard numbers, but again, it's typically someone who's drank large amounts daily for over a month. Conservatively, if someone hasn't drank heavily for, has not drank heavily for more than 2 weeks, they're really not at risk for alcohol withdrawal. But to be conservative, we will kind of use that 2-month cutoff, but nothing's really, or sorry, 2-week cutoff, but nothing's really set in stone. And then what heavy drinking means, that's also highly variable. If you look at Europe, they use much higher cutoffs for someone at risk, we say, looking down at the bottom, about 8 standard drinks. So that's, a 12-ounce beer, 4-ounce wine, and 1.5-ounce shot of hard liquor. That's a standard drink for us. If someone's drinking more than 8 of those, we say they're at risk, but just because someone's drinking less than those doesn't mean they're not at risk. So it's really highly variable. But these are general guidelines for who will be at risk. So if you're drinking less than 8 standard drinks a day and not daily for more than 2 weeks, then they are lower risk to be suffering these severe consequences of alcohol withdrawal. But again, take-home points being if someone has a history of severe alcohol withdrawal, if someone's symptoms are worsening on those scales that we show, or if someone's greater than 65 years old, they're really at increased risk for severe consequences of their alcohol withdrawal and really should undergo observed detox in a medical setting. So this is the pause that I was talking about. So the last 2 points, need to be medically managed. So someone's blood alcohol level that's of greater than 200, that's a 0.20 on the breathalyzer, and then some of the vital signs that would be measured by a healthcare professional. But if you can see, so a positive score for this for someone at risk for moderate or severe alcohol withdrawal is 4. So you can get to a score above 4 just based on history, even without those. So if someone does want to have a more quantitative measure of who's at risk, you can use this scale in the field even without the vital sign measurements and get to a risky score. And then our treatment options. So again, to Carly's point, the goal is to reduce the withdrawal symptoms, but most importantly, prevent seizures, hallucinations, and ultimately death. So our options for that are, an alcohol taper that can be challenging, logistically and psychologically, to really mitigate your risk on your own. What we use in the medical field, the gold standards of benzodiazepine taper. So those are medications, Valium, Xanax, Librium, Ativan type medications that work on one of the same receptors as alcohol, the GABA receptor, so that it gives that signal, that calm down signal that I was talking about earlier, kind of replaces that and then protects against seizures as well as the other withdrawal symptoms, anxiety, insomnia, those as well. And then sometimes, we see these patients in the ICU and they need really high doses via the IV route to get there quickly to really ward off some of the more severe consequences. So this is best to be done in a monitored setting when someone's at risk for the severe withdrawal. So again, to Carly's point, I feel like I'm saying that on repeat. It's not a standard withdrawal protocol for the alcohol taper. It's different for everyone. So again, we realize that not everyone is going to seek care. Not everyone's comfortable in the healthcare setting. Not everyone is able to get to the hospital or be admitted. So in a harm reduction approach, it's not, hey, I'm telling you, go to the hospital, you're not going to the hospital, good luck. It's making general recommendations and, meeting someone where they're at. So those general recommendations are, if you can decrease your consumption, the longer and more protracted and slower you can go, the safer it is. But again, if someone's abruptly cut off, that's not always an option. And so general recommendations: safely decrease your alcohol intake by 2 standard drinks a day, and that's not going to put you at increased risk. And you shouldn't really feel too crummy. But again, if you're drinking 20, 30, 50 standard drinks a day, this is going to be a very prolonged taper, and that's not realistic for someone who has abrupt cessation of their supply. A quicker route, you're going to be feeling much more crummy and increased risk for severe withdrawal, but decreasing your alcohol consumption by a half each day. So, if you drink a 30-pack a day, drinking 15 beers the next day, 8 beers the next day, 4 beers the next day, that's a pretty quick taper, but that'll be lower risk than, just stopping immediately. And then always important, to slow the taper. If you go from a 30-pack down to 15 and you're feeling terrible, stay at 15 for a couple days. slow down that taper, or reconsider going into an observed setting for your withdrawal symptoms. And so treatment options, again, this is potentially fatal. So always the nearest emergency department, call 911. I wish I was surprised, and I wish I could refute, the anecdote about the patient not being treated because they presented for that before. It's with this being potentially fatal, easy for me to say. I think you got to risk that stigma and that judgment, because this is a fatal disease. If that means going to a different emergency department, or pulling strings with a provider, to call in ahead of time. Hey, Dr. Clark, this guy's really at risk. He's been treated terribly before. Would you mind calling the emergency department? Something like that, really, just to kind of grease the wheels, because this has real fatal consequences. It needs to be taken seriously. So nearest emergency department, 911. And then here in Rhode Island, we have a few inpatient detox options. Again, we do this at the hospital, at Rhode Island Hospital, a lot, but specifically designated units are at Butler. There's the contact information there, and Roger Williams. They do still have their inpatient detox program. And then Phoenix House can do a detox as well. If it's someone who's at high risk and needs IV medications, the only place that does that is really Roger Williams or an inpatient hospital setting. And then outpatient management. We don't have a lot of good options for that, for someone being prescribed a benzodiazepine taper. But these are unprecedented times, so we're beefing up our response, in case this does need to be more widely distributed. Working with Behavioral Health Pharmacy in Genoa, who is ready and willing to pill pack these regimens and get them out there when needed. But for the time being, if your primary care physician is comfortable and able to prescribe this, that's something that they are licensed to do. It just depends on patient or physician comfort and ability to feel comfortable with these medications. Butler does do an outpatient alcohol detox, usually in conjunction with their IOP and PHP. But again, with these times and not seeing patients in person, they may be able to do that without the counseling piece if the patient's not interested. And then at Lifespan Recovery Center, we don't do a lot of this, but don't want anyone going without treatment. So if someone's not comfortable with the other options, give us a call. We'll meet the patient where they're at, figure out what they need and what we can do. So that's always an option. Again, take home points, easy for me to say as a physician, but if someone's at risk based on their history, based on their age, based on their heavy alcohol consumption, and looking at abrupt cessation, this can kill them. We need to do everything we can to get them into an observed treatment facility. So history of prior withdrawal requiring hospitalization, history of withdrawal seizures, delirium tremens, or if the withdrawal symptoms just aren't getting better over the first day, we need to pull out the stops, whether that's, again, pulling the strings and talking to physicians that that can help get the person into the appropriate setting, and just helping to describe the severity of the consequences, to the patient. So hope that makes sense. I hope I didn't go too fast, and let us know at the end if you have any questions.
That's great. Thank you, Seth. Laura, would you like to finish?
Sure. Yeah, thanks. Thank you so much for putting this on. I think what comes to mind initially, just as a therapist and as I do a lot of community work, is that I think sometimes we talk about strategies as if we're going to be in isolation working with our clients and our consumers, and we really aren't. Like, we have a wealth of knowledge and a number of colleagues who we can reach out to for support and to check in with for consultation. So I hope that we leave everybody who's watching with that, because nobody has to make a decision in isolation. There's definitely people that you can all reach out to. And I think Carly and I put our information on there. So if anybody ever needs to ask me a question, I'm certainly available as best I can. A little more about me, just so that you all know who's speaking. Most of the work in education that I do is clinical instruction. And in New Jersey, I would teach the courses that are required from the state for drug and alcohol counselors. So, and I say that because, what I have found with my students and also in myself is that, rarely do we come to this work with an absence of our own personal history and stories in some capacity. And it's, so much of being an effective, whatever, doctor, clinician, psychotherapist, peer support specialist, so much of that involves really not only being forward facing, but actually looking inward and seeing like, how is this work affecting us? Because in order to come to the work effectively, we have to be grounded and have clarity, and make sure that our efforts aren't really mixed up in our own history, in a way that it's going to negatively influence. And I'll get to that. I mean, of course we want first person experience, and that's not what I'm trying to say, but the self-reflection piece and the grounding piece, what it does is it gets us into like the right part of our brain when we're making decisions. So if you look at this from a trauma-informed perspective, we're not going to be reacting to this fear and sense of urgency that might be coming from our own experiences. We're going to be like, our prefrontal cortex is going to be online, and we're going to be able to think with a little bit more clarity and like really muster up that, or the way that I usually phrase it is we're going to be able to find our center, and our center is always in what does this client need, not, oh my gosh, I'm afraid of what might happen to this client, right? I hope that makes sense. And, trauma survivors, and I think that a lot of trauma survivors are in this field, I think have to be especially careful right now because we're all experiencing a collective trauma. And so it's bound to sort of ruffle up some of the experiences that we might have had of feeling helpless or of feeling fearful that maybe we won't have access to our supply, or maybe just feeling fearful because we have experiences with loved ones and clients and friends and family maybe dying, right? So, we're all operating, the dial has switched up, I think, for most of us in that we're all operating with like a nervous system that's a little bit more amped up. And so how might that interfere with some of these choices that we have to make when we decide what is our lane, right? So I do want to offer that, I think it's really important to be thinking of self-care and community care for ourselves as a discipline right now. That's part of our work. That's the foundation of our work, because if I'm not resourced and taking care of myself and feeling secure with my feet on the ground, and if I don't have people that I can really feel like I can rely on, it's going to be really hard for me to feel grounded in my work with somebody else in their trauma. Those things start to become a little bit messy and intertwined in a way that it just sort of mucks up the work. So how do you resource? I think that that's something that a lot of my colleagues have been talking about in our own group sessions. It's like, what do you do before you meet the client where they're at? How do you ground yourself? How do you know if you're in your stuff or if you are really feeling clear and ready for the work with somebody else? And I'm just going to tell you, like, some things that I do is I come from a somatic sort of point of view. So before I even talk to somebody, I have like a ritual that I do. Like, I have things in my space that comfort me. I have things that ground me. I have a personal spiritual practice, and I even will push my back against my chair sometimes, or if I'm feeling that fluttery, anxious urgency, I'll stand up between sessions and I'll push on a wall just to kind of get that energy out, because that anxious energy can really make it, can cloud your ability to see the situation clearly. I was saying to John, or I was writing to John when I was thinking about what I was going to say, that it feels a lot to me right now like I'm in one of those medical dramas where you're in a restaurant and somebody is choking and they have to cut an airway and use a straw and all this kind of stuff. And I feel like that kind of urgency is present right now for a lot of us. Maybe I just have to make do with something because this person's going to die if I don't jump in and do something extreme. And when I think about that, I'm like, first of all, I've never seen that happen. And second of all, do people really survive that? I don't think they do. I don't know. They probably do, but I'm not a doctor and I can't do it. So while the impulse is there to be going above and beyond my capacity and quite frankly, my scope of practice, that's a normal feeling. without grounding and without having these techniques to sort of tend to our own internal traumas, we could potentially put people at risk. I mean, not to that extreme, but I would hope, but in some other way, shape or form. And it's unintentional, but if the impact is really dangerous, I think we need to really think about strategies to avoid that. So what is our scope of practice? I mean, I've been thinking about the clients that I've worked with who, don't want to go to an inpatient facility or don't want to go to the emergency room. And for my clients, a lot of it's due to discrimination. I work with a lot of queer people, a lot of trans people. And so, in my work, I know if we're getting to that point, that means most likely there's going to be another trauma to process on the other end, right? So how do I, how do I stay in my lane and not, I can't, like much like Carly said, I can't give people like a certain amount of drinks to go, titrate down. I don't have that experience. That's not my lane. What I do have is, resources like Carly talked about, HAMS, and there's other organizations, harm reduction organizations that can maybe help facilitate that. So that's always an option. I personally try to get some sort of medical professional on board, but those are my professional boundaries. So in my life, I have a nurse practitioner and a psychiatrist that I talk to frequently, just, as a team practice sort of. And I have like a nutritionist for some of my clients. So like my boundary is like, sometimes we need a team and you get to choose who's on that team. But this is the discipline they have to be in, right? And everybody has a harm reduction perspective, but if the danger is to the point where I don't feel like I can professionally and personally be grounded in my work and in my life, like that's a choice that I have to make. And I think that everybody has those choices that they have to make, and everybody might have a different line. And that's great because our clients need different things. And so it's really important to take inventory and say, like, this is what I have the capacity to do. So you're not overextending yourself. And that's a lot of times that's ethical, but sometimes that's, ethical to yourself and to your history and to what you really have the bandwidth to work with. So my scope of practice, right now, I think where I'm personally sort of getting consultation is around like, when does psychoeducation become medical advice, right? And because we don't want to be giving people information that a medical doctor really should be overseeing. And that includes all of the stuff that, our wonderful doctor contributor gave you. So I'll let him be the owner of that information. But yeah, I think psychoeducation for us is just sort of like a broad brush understanding of the general risks of especially immediate discontinuation of alcohol use. And then, some options for how that oversight can happen. I will say, like, we all will probably have certain clients that will be more likely to hand off to trusted supports in their environment. For me, I've got some clients who just don't have any, right? And so it becomes way more high risk. And then I have some who have really strong family support who can monitor 24/7 and who are trusted by my client, which is like amazing. And that's what we all want. But, sometimes it varies based on the client that you're working with for a wide variety of reasons. And that's like a whole other hour presentation. But really what I'm looking for, aside from the physical risk, is just environmental risk. Can this person detox safely in their home? And that could be, everything from interpersonal violence to, does this person have a history of suicidality? Like, that could be exacerbated by this. Does this person have, chronic major depressive disorder, past suicide attempts, panic attacks, So, I'm always thinking about that piece. And I guess the final thing I want to say is just to piggyback after what Dr. Seth had said is the handoff, like the importance of the handoff, because there are certainly times when my clients do have to go to a higher level of care, and we have that open conversation, especially with my trans clients, which is like, okay, you know, yes, you're probably going to be misgendered. And yes, I don't know what the bathrooms are like, but I'm going to find that out for you. And I'm going to make a nice warm handoff to somebody and have a point of contact so that I can be with you every step of the way. And that's an engagement that I have chosen to do. Not all outpatient therapists will do that. But you know, I'd encourage you, if you do have the capacity, to think of that, because if the reason why your client or the person you're supporting is not going to the hospital because of something like that, you might be able to have an impact on the environment so that they can, you know, have a better experience. And, you know, I'm always thinking at the macro level too, like you might be able to change the environment a little bit for whoever comes next. Not that that has to be the center, but, you know, I'm always sort of thinking in that way. And also creating sort of linkage in different environments so that, you know, we're changing systems while we're advocating, you know, for individual needs. Is there anything else that I was going to say? I don't know. If anybody has questions about telehealth and all this too, I mean, I'd be more than happy to speak to that, because that adds another layer, you know. We don't have like the neural Wi-Fi that usually happens in an actual room when we're sort of co-regulating with our clients. And I think that's for me been something that's new to navigate. But there are ways that we can. So I'm happy to speak to that as well. But I don't want to go on and on. I think I've said enough.
That's great. Thank you, everyone. That was fantastic. I will say we will send out Seth's slides, and we'll send out links to the organizations that Carly mentioned and a few other links. So we've saved 15 minutes for questions. One question that I saw came up on the chat was, what about providing people with alcohol? Which from my point of view is a perfectly good harm reduction strategy. If you can prevent somebody from going into withdrawal in the first place, that's obviously preferable to managing unanticipated withdrawal. However, I've seen people write about organizations facing a lot of dilemmas when asking if they can and how they can provide alcohol. I do not know how that would be seen by the licensing board for peer recovery specialists in Rhode Island, but I can imagine there could be issues in it. So that might be something that I'm not sure that I would do in my role as a peer recovery specialist, but would look for other people who could fulfill that role, maybe.
Wouldn't do it within my work, and so I work for our state crisis line, and we have a peer line for it. So all of our stuff is telephonic, so we don't have that in person anyways. However, I would encourage people to start building some mutual aid groups, which I think that is where we're getting to more providing of that safe supply that is out of the professional realm, but really still maintaining those peer support values.
There's a question on chat. Seth, could you explain what DT is again? Thanks.
Yeah, so those are delirium tremens. So that's typically used to describe the fatal consequences of alcohol. So the delirium part where someone starts to have hallucinations and just some encephalopathy symptoms, and tremens from the seizure. So really that's used synonymously for withdrawal seizures, withdrawal hallucinations, indicating the fatal consequences of end-stage alcohol withdrawal.
A question to everyone. Any affordable telehealth therapy that people have found useful and easy for patient clients to use?
Yeah, I just responded to that. So I use a software called Doxy, which is very user-friendly, affordable, I guess is, you know, subjective. Right now I'm spending like $30 a month because I have a free 6-month trial. I intend to probably be using it for a long, long time, and that fits my budget. There are some of the electronic medical records for outpatient therapists have a teletherapy component to it that you can add on for like an extra. The last one I was using was like $10 a month. I think Zoom has a specific package you can purchase that's HIPAA compliant. I'd have to look into that for you, but I I think a lot of the softwares are also offering at least free trials for a lengthier period of time than they normally would because of everything going on. So that's something that you could probably look into.
Other questions?
I'm wondering if anybody has a recommendation for online groups for alcohol that take kind of a very pronounced harm reduction approach that they can that they would advocate for.
Yeah, so the three I mentioned are all online virtual format. I have probably heard the most about HAMS in a good way. However, I think also one of the runners of it, Ken, I forget his name, tends to be the only voice you hear. So I would love to hear more voices in the moderation management community. I would also look into Smart Recovery. Technically, they run abstinence only, but I think they're much more focused on changing behavior than they are on like the final output of abstinent. So I think those are all good. If you go on to, oh no, help me out. Massachusetts has a huge organization and they're running recovery, all kinds of recovery virtual meetings. I will look into and send it to John to disseminate, but that includes substance use recovery, suicide recovery, eating disorder, whole plethora, which as we know, oftentimes substance use is the coping mechanism for other issues. And I think a lot of the times we focus on taking away the coping mechanism and not on those issues. So I would encourage people to, if online support meetings are helpful to them, to join a variety of them.
Yeah, Unity Recovery in Philadelphia is offering all recovery meetings that are very safe space for people practicing harm reduction recovery. In my experience, I agree with Carly. In my experience, Smart, though abstinence oriented, recognizes that many people don't just quit all of a sudden and can be much more open to a gradual process. I mean, this comes up in conversations between us all the time. There's a great need to start harm reduction mutual aid groups. And there's one in Massachusetts, Harm Reduction Works. That might be a model for it, but it's something that RICARES is talking about starting in Rhode Island as soon as we can. Other questions or thoughts?
Really quick, it is Western Mass Healing and Recovery Learning Community. So they are offering a ton of virtual support groups for a myriad of reasons.
I just seeing a question from Dr. Peterson here about tips for telemedicine. So, you know, what I have found is that some clients, I didn't even think about this until it was pointed out to me, but like even the screen on my telehealth software, I thought I was in the center of the frame and I was actually like right here. I think that I didn't really realize that until one of my clients pointed it out to me. And so I would really recommend, if you're using telehealth, get a good friend on it and just, try and ask a lot of questions about what it feels like where you are in the frame. That's one thing that's really important. As I'm moving my hands, that's another thing, is to make sure that, even if your hand, this could feel very threatening, right? So you want to be really careful about your body language as it comes through the screen. And then, when I'm thinking about sort of somatic I'm a sensory motor psychotherapist, so I do a lot of work with, what are you feeling in the body? And I can't really track like I would if I was in a session. So I'm doing a lot of work on helping clients to sort of be that tracker with me. And that's been really helpful. So I'll say things like, what is it like when like, what's going on with your body right now? Because I can't see. And I'm wondering if like you can just sort of do a quick scan and tell me how this conversation is reacting. How is it landing, right? What's it like to be talking to me through a screen? How is it different in your body as we do this? And you'd be surprised at how that gets access. You get access to some really rich material in that, and people get a more solid awareness of where they are emotionally, just by doing a quick sort of, help me understand what's going on because I can't see, And then the other thing is, I have been working with a lot of people who are in, some pretty crisis situations. I work right outside of Manhattan, so there's a lot of trauma right now, as there is everywhere, right? But and so I can't, I think that there is, it's more difficult to really co-regulate emotion when you're not in the room with somebody. And so I've been relying a lot on like speech prosody, like using ups and downs in my voice. Because if you think about like when babies are young, it's not like, stop crying, everything's fine, everything's gonna be okay, right? Hey, it's all right, everything's good. And so you don't wanna be infantilizing people, but you really do wanna use that up and down tone in your voice, because it does convey safety and security, and it's more grounded. And I would encourage people to just check in and ask people like, how is my voice for you? Do I feel amped up? Like right now I feel like I'm probably a little amped up because I'm a little nervous, but I think if, it will help to regulate your client's emotions. You can use your voice, you can use your eyes, like a crinkle in the eyes can be a safety, right? So there's ways that you can sort of scratch that itch of co-regulation without being in the room with the person that I think are really important. Because again, everybody's dial is up. Like if you started at a 6 before this, we're all starting at an 8 now. So it just, gives you the opportunity to just switch it a little bit and, take it down a notch. I'm not sure if that's helpful. That's been helpful for me and my clients.
That's great. So I wanted to end quickly on the trauma piece and to plug the next RICARES event. At RICARES, we've been talking a lot about what it means to be a good enough peer, recognizing that normal trauma response often is to overcompensate for the failed systems and structures we work in, to overcompensate for the pain of the people we care about, to overcompensate for problems of support in our own agencies. So, sometimes as peer recovery specialists, we talk about ethics as if in their one box and trauma as if it's in another box. But a lot of the ethical missteps or problems that we see are actually connected to areas where people have trauma. We are doing a monthly group at RICARES with Anna Bess Moyer Bell, who is a drama therapist. That's a kind of drama therapy workshop for peer recovery specialists. It's a place, it's not really like going to therapy. It doesn't feel like that at all. It's in part you're learning drama therapy techniques that you could learn with peers, but they also are very useful in terms of your own recovery, your own self-monitoring, your own resilience. So the topic of the next one, which is Thursday, will be how to be a good enough peer. Really to think about what kinds of obligations we're assuming and not assuming in the context of COVID-19 and this experience of collective trauma as it was described. Thank you very much, Carly, Seth, and Laura. It's great to see all of you by Twitter. Anyone who's not on the RICARES mailing list, we regularly hold events of this kind, and you're always welcome. Thank you for joining us today, and I hope to see you all soon.